I'm delighted to introduce you to Professor Ian Olver, and when he comes up you'll recognise he's the bloke who's been waving his finger at you on the telly about alcohol and cancer, and that's another story for another day. Ian graduated from the University of Melbourne in 1976 and completed his Doctorate of Medicine in 1991. His work goes across the area of clinical trials, bioethics, has been a medical oncologist at Melbourne, at Adelaide Hospital, Royal Adelaide Hospital for many years, and in 2006 was appointed the Chief Executive Officer of the Cancer Council Australia, our national body. He has various appointments across universities around Australia and is still a very active researcher and has an international reputation in a number of cancer fields. His achievements are long and detailed, and we'd take up half the lecture if I went through them all, so I will skip some of those, and I'm delighted to introduce you to Professor Ian Olver. Ian.
Thanks, Terry, and thanks to Cancer Council Western Australia for this series and for inviting me across. It's always nice to come to Perth. I've been asked to talk about the top 10 wins against cancer, and what I could have done is I could have taken the treatments and talked about the new whiz-bang treatments, and I'm going to mention that, but I decided to take a broader look at it and to look right across the spectrum of what we've done in prevention, screening, treatment, supportive care, but also how we organise cancer services, because that's also impacted on how well we do. And this is a bit like giving 10 mini lectures in one, so question time is going to be very important to fill in the bits that you want more detail out. So it's going to be quite a romp through topics that go from prevention to health services research and try and pick out a top 10 that makes sense. I started off with one of the great successes in terms of reducing cancer, and that's tobacco control. Because each year more Australians are killed by tobacco than breast cancer, AIDS, traffic accidents and murders and suicides combined. Smoking's responsible for over 19,000 deaths each year. It causes 1 in 5 cancer deaths, and it's now lung cancer, although not all of it smoking related, lung cancer is now killing more women than breast cancer. So that's how serious tobacco is and how important tobacco control is. It's estimated that nearly $6 billion is lost in workplace productivity, 318 million is spent in direct health system costs, and there's 31.5 billion costs associated with tobacco use in Australia. So to have an impact on the health system and cancer, tobacco control is very important. And the interesting thing is, some of the most effective measures haven't required a lot of money. They've just been policy changes, cultural shifts on whether we can advertise tobacco and how it's promoted. So the 176 million spent on anti-smoking campaigns over the last couple of decades has given an estimated 8.6 billion in benefits. So a very small investment has had a tremendous impact. And it's estimated over the last 35 years that the government-led tobacco control measures have prevented 17,000 premature Australian deaths from tobacco-related disease. This is a graph that actually shows what happened to tobacco consumption, and it really all started in the 70s when we started to restrict tobacco ads. That's the first time we started to get traction on tobacco consumption, and slowly as the print ads disappeared, the electronic ads disappeared, the billboards disappeared, the sponsorship of sport disappeared, we started to see a fall in tobacco consumption. Nowadays, the most effective thing we can do is actually the price of tobacco. So we need to put the tax up. And the World Bank has estimated right around the world that for every 10% increase in the actual price of a packet of cigarettes, your smoking incidence in most countries goes down somewhere between 3 and 4%. So we know how to drive consumption down, because the price of a pack is a very strong motivator to quit. Other strategies, and particularly one you've heard of lately, is plain packaging. That's not going to necessarily affect current smoking rates. That's designed to stop young smokers being attracted to the pack. So we're now down to 15.1%. In 1974, it was sort of in the mid 45% of adults that smoke. So that's been the efficacy of the program. And of course, when the government does put the tax up and puts it up by a lot, like happened in April in 2010, it actually nets money that can then be used in the health system, and a 21% increase would net over $1 billion. So there's benefits beyond that. And in 2010, the government announced plain packaging to eliminate one of the last vestiges of advertising. It circumvented the practice of tobacco companies of trying to blunt the health warnings by changing the colour of the packs and make them tone out. And it also circumvented the practice when tobacco companies weren't allowed to advertise low-harm cigarettes like light and mild anymore. They simply put the low-harm ones in different coloured packs and told the tobacconists that that's what they needed to advertise. So all of that gets rid of in the plain packaging. And we know from research done on young people and showing them various packages that the pack does attract smokers. And if you have a drab pack, and the proposal in Australia is to have olive brown packs, then smokers are not attracted, young people are not attracted to that colour. And what's more, if you have an awful pack, they think the contents are awful. So they're not attracted to trying the contents either. So that's the work that's done. So I'm putting up as our the top one in our top 10 that tobacco control has saved more lives than just about anything else we've done. And at 15%, we've still got a long way to go to get to zero, when we'd save the maximum lives from something that's entirely preventable. The next thing that we're going to talk about is also in prevention, and this is Ian Fraser, who helped develop a vaccine against the human papilloma virus, which is responsible for cancer of the cervix. And by vaccinating all the girls, as has been done over the last 2 or 3 years, we should be able to further reduce cancer of the cervix by about 70% in this country, because that's the sort of coverage of the vaccine. So there's been a couple of vaccines have developed. They prevent cancer because they prevent the common types of human papilloma virus, 16 and 18. We have to tell people, though, with the vaccination program, that because it isn't 100% effective, because there are still some other types of virus that can cause cancer, that we're going to have to continue the pap smear program on, but not forever. As time goes on, we will have to change how we screen people. And already, just 3 years into the program, we've been able to show an impact in that girls under 18 have less high-grade lesions in their cervix that lead to cancer of the cervix than they did 3 years ago. So within 3 years of introducing the campaign and vaccinating women, we've been able to see an impact. And of course, as we go on, we'll eventually see an impact in incidence and then mortality from cancer of the cervix. And of course, Australia, because of the successful pap smear program, already had a tremendous record in cancer of the cervix. If you put this vaccination program into the developing countries where the incidence of cancer of the cervix is actually very high, it'll have tremendous impact of saving hundreds of thousands of lives over time. Recently, you may be aware that the government announced that it's going to actually extend the vaccination to boys. Now, that will actually help boys because there are some cancers, like cancers of the head and neck, that are related to the vaccine as well as some of the genital cancers. So boys will actually have those rarer cancers reduced. But it will also reduce the amount of the virus in the community, so even unvaccinated girls are less likely to pick up the virus, which is a sexually transmitted disease. So the government, in vaccinating boys and girls, and it's a very safe vaccine, there have been millions of doses given now, so we know that, will drive down the incidence of cancer of the cervix, but also other cancers. The third prevention thing I want to talk about is a story in evolution, but it's a really interesting story because you often have stories in the press of some whiz-bang new anti-cancer treatment that costs, $100,000 a time. Well, there's beginning to be a story that taking aspirin, which probably costs a few cents a time, may actually do an awful lot to prevent cancers, particularly a common cancer like bowel cancer. And I'll just show you what we know to date because it's a really interesting evolving story. What happened is a British researcher, John Rothwell, was looking at the studies and there's quite a lot of them, where they're using low-dose aspirin, 75, 100 milligrams, brands like Cartier and so on, and they're using the low-dose aspirin to try and prevent you having a heart attack or a stroke, particularly if you've already had some symptoms. And so they've been doing those studies of low-dose aspirin against heart attacks and strokes for years. And he said, well, I wonder what would happen if we looked at the difference between those taking aspirin and those not taking aspirin on cancer. So although the study wasn't designed to look at that, he looked at it anyway. And to his surprise, I think, the difference between something like bowel cancer in the group that had been taking aspirin and those that hadn't was something like about 60%. It wasn't some tiny little number that could be a statistical error. It was quite a significant reduction in cancer. So the next study that was done was actually a study of people at high risk of getting bowel cancer. They've got a genetic predisposition called Lynch syndrome, which means genetically they're more likely to get bowel cancer. And so they were randomly allocated to receiving aspirin or not. Only in this study, they were actually getting, big dose aspirin, two tablets a day, 600 milligrams of aspirin, sort of, the 2 tablets you'd take for a headache. They were taking that every day. And when they initially had a look at this study, they thought, there's no difference, it doesn't work, because they looked at it a couple of years after it started. But it turns out that you've got to take the aspirin for at least 2 years before you see any effect. So when they analysed it later on than that, they found that for anyone that had taken aspirin for 2 years, they were beginning to see the same decrease in the incidence of bowel cancer as Rothwell had found in the cardiovascular studies. So we know that taking aspirin, if you're at high risk of getting bowel cancer, can prevent you developing bowel cancer, which is really quite interesting for such a drug that's been around forever. But we can't recommend it to anyone yet for the following reasons. We've taken this specific high-risk group and done the randomised study, but what about everyone at low or moderate risk in the rest of the population? Can we tell them to take aspirin? Well, no one's done that study, so we don't know what the impact would be. What about the side effects of aspirin? And the ones that are most of worry here is that you bleed when you're on aspirin, and you can bleed into your bowel, or, more dangerously, you can bleed into your head. So you don't want to take aspirin trivially, and anyone that thinks they should take it at least should go to their doctor to find out if they've got any particular propensity to bleed. The good news on the bleeding is that subsequent studies have actually shown that the longer you take aspirin in the population, the less people bleed. But that may be because they all bled in the first couple of years, and anyone that didn't bleed early isn't going to bleed later on. So if you're taking it over several years, you don't keep increasing your chance of bleeding. On the other hand, you don't want to be taking it for a trivial reason, if you like, and then have a serious thing like a brain hemorrhage. But the other question that we still don't know is what dose are we going to recommend if we recommend this? Are we going to need the high dose that they did in the Lynch syndrome study, or the little 75 milligrams that you take for cardiovascular disease? And there's a current study being done again in high dose patients to try and figure out that dose. What we do know is you've got to take it daily, and we do know that you've got to take it for at least 2 years, but we don't know where the balance between the getting an impact on the cancers and the risk of bleeding lays. So we can't at the moment recommend it. However, it's a very interesting finding that will continue to be researched, and it may be a very simple way of preventing cancers, because what's been found is not only bowel cancer, there are several other cancers that have been influenced and prevented by taking aspirin in the studies that have been done. So watch this space. This isn't hundreds of thousands of dollars, this is a few cents. Okay, so if we move on from prevention to screening, we now have population screening tests for breast cancer, the mammograms, cancer of the cervix, the pap smears, and now, thank heavens, they've finally announced the completion of the bowel screening program. So in the next decade or so, everyone 50 and over will be sent the bowel screening kits every couple of years to look for blood in their bowel, and if they have it, they'll go on to have a colonoscopy. In breast cancer, we're beginning to see the mortality from breast cancer, which is on the slide nearest to me. We're beginning to see it dip. The incidence goes up because the incidence goes up in an ageing population, but the death rate from it goes down. Now, the death rate from this is due to two things. It's due to better treatment and it's due to screening. And there's a bit of an argument in the literature about how much each contributes. But I think if you look at the international literature, you could say it's about half-half. So we're still recommending breast screening and of course, the best treatments available. Who to screen? Well, the group in which breast screen is going to be most effective is the 50 to 69 years old. It's going to be somewhat effective in the 40 to 49, but it won't prevent anything like as many deaths, and you do have some downsides in terms of radiation doses. And so, although we could screen, we should certainly be screening the high-risk women in that group, but it's not mandatory at the moment. And once we get below 40, it's very difficult to use mammograms because the reason, as you see on this mammogram here, you can pick a cancer, is the cancer's white and the breast is black. And that's because the breast, as you get older, gets more fat replaced, which is the black. In young women, the breast looks actually quite white on an X-ray, and you just can't pick the cancer out of it. So it's not a great test for the under 40s. People are looking at MRIs and other types of scans. But for routine screening, the target group is 50 to 69 with a mammogram. With cancer of the cervix, as I said, it's been one of the great success stories. The incidence has halved from 17.2% to 7.3% since the screening program is in 1991, and the death rate has decreased from 4% to 1.8%. So it's really made an enormous impact, and that's why it's in the top 10. And now finally, we have bowel cancer screening. Why is that so important? Well, because the survival in bowel cancer does depend on how far the cancer's penetrated through the bowel wall. If it's just sitting right in the middle, your 5 years right on the on the bowel wall without going through it, your 5-year survival is nearly 90%. As soon as it's gone through the bowel wall, even if it's into the first lymph nodes and you can take them all, your 5-year survival drops to 43%. So early detection is absolutely vital. And what it's been found, even with the program that's only been screening 3 age groups, is already we're tripling the number of people that are presenting at the early stage where you're potentially curable 90% of the time. So that's a big impact, even just sending out the kits to 3 age groups. But there's another important thing about bowel screening is you can actually prevent cancer altogether, because most bowel cancers start with polyps. So if you can find a polyp that bleeds and get rid of it, you won't ever develop cancer in the first place. So the reason screening's in the top 10 is not only early detection when it's curable, but in some cases prevention. And that's just like cancer of the cervix, where you can pick these precancerous lesions and do something about it. And what's more, in terms of polyps, they often take many, many months to change or develop into anything else, or sometimes years. Most of them never progress, but if you get rid of them, they absolutely won't progress, and you'll stop cancer occurring. For those who have the bowel screening test, where you test your bowel motions for blood, about 5% who test positive diagnosed with bowel cancer. Some of those will have the polyps, the adenomas, 40 to 45%, so you'll be preventing them getting cancer. And the remainder that test positive usually have non-cancerous causes like bleeding hemorrhoids, for example. And if you have, some people say, why don't you screen with a colonoscopy? Well, it's a very expensive, invasive thing to do. If you have the fecal occult blood test first, you increase the likelihood of finding cancer by between 12 and 40 times. So you're then only doing your colonoscopies on the people that are most likely to find bowel cancer. And we calculate that screening for bowel cancer could reduce mortality in the over 50 age group by between 30 and 40%. So that's why that one's in my top 10. And in fact, we've somewhere between 500 and 1,000 lives will be saved when we complete the bowel screening program. However, at the moment, only about 40% of people who get the kits are actually sending them back. So there's a lot in waste paper baskets, and we've got to step up that rate because it could save your life. Just a little glimpse into the future. The future of screening may be that everyone gets their whole genetic sequence done and we know what propensities they have for cancer and can take some preventative steps. So the future is to do your fingerprint of what all your genes are doing and what your chances of getting a cancer are. And already to screen someone's whole genome is down to $1,000 a test. It used to be horrendously expensive. Once it gets down to $100 a test, I think everyone will just about have it at birth, and that'll be the screening. So that's the future of screening for cancer and all sorts of diseases. We live in a very exciting time. People worry about the economics, but in cancer and in disease, our chance of detecting disease through the new knowledge about the genes is quite remarkable. So now I'm going to go on to treatment, which is the sort of really exciting stuff, and really it springs from that slide I've just shown, because our new treatments are targeted and personalised. Chemotherapy, as we know it, drug therapy for cancer, started in earnest after the Second World War, and they used mustard compounds. And the picture I've got there is of a battleship blowing up in Bari Harbour in Italy during the Second World War, and it was carrying mustard gas. And the ship's surgeon carefully documented that all the people that were exposed, their lymph nodes shrunk and their bone marrow did as well. So doctors back in Yale started thinking that mustard compounds might be very good for treating lymphoma. And indeed, that's exactly what happened, and the first cytotoxics are born. The problem with these drugs is when you give them, they kill all the cells in the body that are dividing, not just the cancer ones. The normal body cells have a chance to recover, the cancer doesn't, so that's why you get a differential effect. The cancer progressively gets knocked down, whereas the normal body cells can recover. But it's a pretty primitive way of doing it. If we could target the tumour better, we could do far better, and that's what is happening now. Because the chemotherapy, because it knocks down everything, it has a whole lot of side effects. Now, I put a slide not to be read. This is a shock and awe slide just about how many side effects there are with chemotherapy. And, things like the bone marrow, your hair follicles, the lining of your mouth, they're all tissues with a high turnover rate where a lot of cells are dividing. So when you give chemotherapy, they get knocked too. And that's why you get so many side effects. But as was announced in Time a decade or so ago, there are new drugs against cancer that are targeted that will allow us to personalise cancer treatment. And there's a whole lot of examples. You don't have to remember names, but I think most people are aware of Herceptin for breast cancer, which really made a great impact. And so with either antibodies that target various defective gene products or small molecules that do it, we've been able to target something about the tumour that isn't on the normal body cells. Because all a tumour is a cell with defective genes in it. That's what the diagnosis of cancer is. And the defective genes produce products that allow the cell to grow out of control. So if you can block that happening, then you've killed the cancer. And so what we're now doing is finding out what those gene products are and how to block them so they can't signal to the cancer how to grow. And the rationale is here. There are either antibodies in that bottom panel, and all I want to show you in the top panel, if you look at the little green molecule sitting in the big pink bit, the drug would be the purple molecule in the next one. It mimics the size. It's like putting a key in a lock, but a key that won't open the door. So you block the lock, but you don't open the door to the cancer growing. And these new targeted therapies do that to perfection. And because the targets are only on cancer, you get very specific therapy. It doesn't have all the side effects on the rapidly dividing tissue. And if the tumour doesn't have the target, you don't give it the therapy. And that means you can be more selective about with patients that are more likely to respond. So we'll get rid of that. Now, one of the early drugs, and this is probably just fortuitous, that was one of these small molecules that targeted a particular genetic product called tyrosine kinase inhibitor, a signalling molecule, was found to be effective in chronic myeloid leukemia, but also in a very rare tumour called a GIST tumour. And there were two things that were neat about that. One was that GIST tumours could be removed surgically, but they couldn't. These are tumours in the bowel usually, but they didn't respond to either radiotherapy or chemotherapy. It didn't matter what you gave them, nothing happened. The other thing about GIST tumours is the particular gene defect in them and the product produced by it was actually the thing that was causing them to grow. It was the thing that was signalling growth. So when it was blocked by Gleevec, the tumours stopped growing. And we saw GIST tumours like this one, a big mass, that variegated thing between the two bones there is a big mass in the pelvis. And if you look at the dates, August 2000 to February 2001, just a few months, all of that had disappeared with Gleevec. And so the proof of principle that these drugs would work was shown with that sort of therapy. And this is even more dramatic. This is a PET scan of a big lump in the liver, that big round lesion with the arrows pointing to it, in December 2000. And just 6 weeks later, after Gleevec, that thing had disappeared. So we knew that we were on to a principle that could probably be applied to a lot of tumours and that we could measure even very early whether they were going to respond or not. So all we have to do, if you like, is to find out what the genes are that are defective, see if we can match the targeted therapies to them, and we'll have far better cancer treatments. And over the last few years, more and more cancers, they're having discovered a therapy that will be targeted to them. I mean, 10 years ago, widespread melanoma, kidney disease couldn't be treated. Now both of those have at least 3 rounds of targeted therapy that can be shot at them. And all the time, and this is something that came out last week in the paper, it's only been done in mice so far, but different ways of targeting the tumour. Here they wrap chemicals in little fat cells and they shoot them at the tumour, they get stuck in the small vessels in the tumour, then they release substances that allow the body's own immune system to deal with the tumour. It stops the tumour blocking the immune system. So very clever ways of targeting tumour, but all along the same line that we're going to be able to specifically target what makes a tumour grow. And of course that's the same principle as we'd use for cancer vaccines. And cancer vaccines could be used to treat existing cancers, or in fact, like the HPV, which is not a cancer vaccine, it's an antiviral vaccine. It's just that it's a virus that is always linked with cancer. With the cancer vaccines, we may be able to immunise someone against getting cancer, and that's the holy grail and the next step in the research against with targeted therapies. And we've already had a vaccine designed to treat prostate cancer, which has increased survival in a big randomised trial. We can target other things as well, and with radiotherapy we can now do 3-dimensional scans and use a particular radiotherapy machine that wraps the radiotherapy beam right round the cancer and decreases the normal tissue. And even in surgery, if you're doing surgery for breast cancer, you can find now the first lymph node that it drains to, called the sentinel node, and maybe if you take that out you don't have to take any more. So it reduces the extent of surgery, particularly under the arm in breast cancer, and should reduce the swelling of the arm that people get. So all the modalities of treatment are being better targeted. So to go on in the talk about the top 10, I now want to talk about a couple of supportive care treatments, because it's all very well trying to cure cancer, but you've got to have a good quality of life while you're doing it. So some of the side effects of cancer need to be dealt with. And this is an Australian discovery at the Walter and Alive Hall in Melbourne, and this was a thing called granulocyte colony stimulating factor, or GCSF. And what this little thing does is it stimulates the development of white blood cells. Now, why that was exciting to cancer researchers when they learned how to make large quantities of it is one of the side effects of chemotherapy is it drops your white blood cells. And if it drops them far enough for long enough, you become incredibly prone to infection, particularly if you're using high-dose therapy with transplants and so on. So the discovery of this molecule allowed people to give higher doses of chemo, which were more effective, because it stimulated the production of the white blood cells just like it does in the body. So there's an Australian discovery. Unfortunately, once it was discovered, there was no one in Australia that had enough money to develop it, and the Americans developed it and literally made billions out of it. And unfortunately, that would be the same today. The other discovery that I just want to talk to you about, because it's sort of neat, it was an area that I was involved in for many years, and that was everyone sort of knew in the early days that if you had chemotherapy, you got nausea and vomiting. And in some cases, it was so bad that people used to abandon their chemotherapy because they couldn't stand that side effect. And over the last couple of decades, people have been looking into all the chemicals in the brain that are responsible for nausea, and they've been looking for drugs that could block them. And basically they've found 2 new classes of drugs over that time, drugs like ondansetron, 5-HT3 receptor antagonists, and drugs like aprepitant, which between them have virtually reduced cancer, vomiting with chemotherapy down to the fact that over 85% of vomiting is now controlled. So that enables us to give the drugs we've got more safely and more comfortably to patients. And I think that deserves to be in the top 10, because from being a problem where it limited people having therapy, we now see people who can have therapy quite comfortably because of these drugs. Nausea is still a problem, not so much the vomiting, but nausea. But we're doing some work at the moment that suggests that one of the reasons nausea may be a problem is it's not like vomiting at all. It has a whole lot of dimensions. Some people call indigestion nausea. Some people call anxiety nausea. Some people call lack of appetite nausea. And our contention is the reason it didn't respond to anti-vomiting drugs was it had all these dimensions to it that vomiting doesn't have, and we probably have to treat all of these if we're going to get rid of it. But watch this space, because we're doing more work on that. I mean, when you're a researcher in nausea, you don't get asked to give too many lunchtime lectures, I have to tell you. Now, I wanted to finish off with something that would otherwise seem totally boring. And why would I put it in my top 10? Because health services research seems to be just an organisational thing. But I have to tell you, one of the things that is about the consistency of cancer treatment, so it doesn't matter if you go to an oncologist who practices in Geraldton or one that practices in Sydney, you ought to get the same treatment if they're both working from the same evidence base. And so what we've been doing is we've been looking at the evidence and producing guidelines for people that are based on that evidence that tells people what the best treatments are. And these guidelines have to be kept up to date, and they'll help the clinicians understand and be able to tell patients what the chances of a treatment working are, what the side effects are, and so on. And the difference between conventional medicine and alternative medicines is the alternative medicines haven't been tested in this way. And often the general public don't understand the difference. So that with a conventional therapy, I might be able to tell you that 2 out of 3 people will respond. That data is never available with alternate therapies. It's only ever promoted by testimonials, for example. And then there are a whole lot of other myths. You know, if something's good for you 10 times as much as 10 times as good, if something's bad for you, cut it out altogether, both of which are not true either. So that's the difference. So evidence-based medicine has really allowed tremendous steps forward in cancer, to the extent that if someone gets cancer today, or of all the people that get cancer today, 63% will still be alive in 5 years' time. And what we're doing now is because of this need and the rapid explosion in knowledge, we're putting our guidelines on a wiki platform so we can change them all the time. And we're making sure that we appraise every paper that comes in, we create a body of evidence, we go out to the public so that they can criticise what we've done, and then we produce guidelines and then look at how many people are using them. The second health services research is multidisciplinary care. Cancer needs many modalities of treatment: surgery, radiotherapy, chemotherapy, immunotherapy. And what has made a big difference in the quality of cancer treatment is when specialists have got together in multidisciplinary teams and they've planned the whole treatment of a patient rather than just doing their bit and handing them on. So it almost sounds like an organisational, boring thing, but it's been very important in the quality of care, and we're still promoting multidisciplinary care across the country. And Cancer Australia, from whom I borrowed this slide, it thinks it's so important that they're developing principles of care, the team approach, involving patients in it, having the full spectrum of treatments available with nationally agreed standards and communicating it. And they've done research that shows it increases both the patient satisfaction and the quality of the treatment. And it's also beneficial to the treating clinicians because they get to communicate with their colleagues and a good working relationship. And it doesn't matter whether you're out in the country, because telemedicine these days can bring the specialists to you in terms of a consultative way. And I was responsible when I practiced in Adelaide for setting up the link between Adelaide and Darwin that is still used for consultations. that completes the multidisciplinary team, so the people in Darwin have access to the same specialists in Adelaide. And my final point, a lot of people, you see a lot of things in the paper about a drug that didn't, get funded by the PBS, and everyone gets up in arms and they talk about the patient that missed out. But in general, in Australia, our pharmaceutical benefit scheme has done pretty well in keeping up with the best and latest and most effective cancer treatments. And the reason we can say that is, sure, they've got to balance the cost of a treatment with how beneficial it'll be and make sure they fund the best treatments. But apart from exceptions of where the life-saving drugs and orphan drugs and immunisation are not part of the program, the reason we know that they've got it right are graphs like this. This shows that this is just cancer survival. Actually, I just picked women with bowel cancer just because it's a common cancer. And you can see Australia in the world is right up there with the leading countries in cancer control. So we've actually got it right and made the appropriate treatments available to people, and that's why we're doing better, as well as funding the screening programs. And what we're going to see is more and more effective treatments. We're going to see more people screened, and the future for cancer prevention and cancer control and cancer treatment is very bright. So I'd like to stop there and invite some questions.